Okay, over to you, Natasha.
Hello, everyone. I'm Dr. Natasha Iyer of the Better, a Medical Center for Complete Living, and our esteemed guest, Dr. Shabnam Daskar. She is our Director of Medical Education. And what I love about her is how up to date she stays with research in all things relevant to healthy aging and longevity. Now, February being Heart Month, we have a lot to share with you, because one of the things that really bothers me is that a person is dying every 36 seconds in North America from a heart attack. Now, this is despite the fact that we are told that everyone with high cholesterol should be on a statin drug, and you've got to eat low fat, and you got to follow the American Heart Association guidelines or the Canadian Heart Association, whatever. And so what is going on that we have such high incidence of heart disease and heart attacks, that people are dying, every 36 seconds? That's shocking. We don't have someone dying of cancer every 36 seconds. We don't have anyone dying of dementia every 36 seconds. And yet when you look around in the media, we spend a lot of time promoting, different diseases, which are all important. I'm not saying that dementia or multiple sclerosis or any of these diseases are not important, but here's a disease that is theoretically preventable, right? Because we're writing all these cholesterol lowering pills, and we're told that cholesterol is the big deal, and we still have a person dying every 36 seconds from a heart attack. So there is more to the story than just your cholesterol and just taking a cholesterol lowering pill. So Dr. Carr, today we're talking about women and heart disease, because as an ER doc, I know this. 26 years ago when I got here, 25 years ago now, sorry, I was in South Africa before then, but when I got here, I will never forget this lady. Her name is Shirley. And she had been to the emergency department 3 days in a row. And she would complain of heartburn and burping, and it's just not settling. And she was just uncomfortable. She was a smoker. She was overweight. She was menopausal. And when I saw her on the fourth day, and back then we didn't know as much as we do now about heart disease and all of that, but I can't tell you why I ran an ECG on her, and yeah, that look, that like, oh my good God look, it was shocking to me. She had changes of having had a heart attack. And then I had, I was scrambling, trying to figure out, but it was already too late. The heart attack had happened already. But she had no classic chest pain. She had no classic, radiating to the jaw or the sweating and the profuse. We have this idea when you're having a heart attack, Dr. Carr, we teach patients, so patients come to us and they go, I've got pain in my chest and it feels like an elephant sitting on me, and the pain's going to my shoulder and down my arm. And then, for some people, it's like up the jaw, up the neck into the jaw. And then they have the sweating and all of that. So when people have anything outside of that, they tend not to come running to the ER or to me and say, can you check me out for something, because they're not sure what it is. So I thought that today, one, we can cover the atypical symptoms of heart attacks or angina even, or anything that's symptomatic of heart disease. And then I would love you to educate our guests on women and what's particular about them in how they present. I mean, I covered a lot with Shirley, but that's just one aspect. And then what makes women so unique, and why are they different from men in how they have a heart attack?
Thank you, Natasha. You've covered a lot of it. Thank you very much. So one of the important things that women need to be aware of, and unfortunately, a recent study showed that less women are aware of their risk for cardiovascular disease. So when I say cardiovascular disease, I mean heart disease and stroke, than they were some time back. So that is not a good way to, to go. We have a lot of work to do. Number
That's
one.
right.
Number two is women and cardiovascular disease, women and heart disease specifically. Though, Natasha, you mentioned that a lot of them have atypical symptoms. One of the important things is, yes, about 70% of women do present with chest pain, but there is a huge 30% of people who will present with what Dr. Iyer described as very atypical symptoms. And some of the atypical symptoms are, there is no chest pain. Sometimes there is only profound fatigue, just fatigue. And unless the ER doctor is someone like you who's aware of what is going on, very often women have been dismissed of as, oh, it's all in your mind, you're going through too much of stress, which is very easy to say, who is not going through stress? Or sometimes this is another rather worrying trend of late, is a lot of younger women are having heart disease. So women in their 30s and 40s, they were not typically thought of as being at risk for heart disease before. And particularly one particular area is women just after giving birth, so postpartum heart problems. And many of those women actually have chest pain because they are younger. Very often they have been sort of dismissed off as, oh, you are too young to get a heart attack. Or, you don't have, so the top 5 risk factors for heart disease and stroke are considered to be, number 1 is obesity. So having excessive body fat percentages. We don't go so much by the BMI as body composition. Number 2 is having hypertension, uncontrolled hypertension. Hypertension is a much bigger risk factor in women than men. Third is having suboptimal levels of blood glucose. That means you may not have diabetes, but your blood glucose levels are climbing. So that is number 3. Of course, number 4 is smoking. Number 5 is abnormal lipids. And today, Dr. Iyer and I are not going into abnormal lipids because that's a huge topic by itself. So these are the top 5 factors of risk factors for heart disease and stroke. But the interesting thing is these top 5 risk factors do not explain all the different heart disease. So what it means is they have found that people who don't have any of these problems, they are not smokers, they are not overweight, their blood pressure is under well control, but despite all of those, they still have had heart problems. So that is called the CHD gap. And that is where, so Dr. Iyer and I, both of us are not cardiologists. So our perspective comes from the view of what can you do to prevent? So obviously to prevent a problem, number 1, you have to know what the problem is. And if women are not aware of their risk, another big area where, a lot of new research is coming up there, because I'm a former OBGYN and I had no idea about any of this. So
you sure know a lot about everything above the waist now.
So Natasha, just like you were talking about your experience 25 years ago, my experience is not even 25 years. I had no idea about all the different obstetrical problems that I was dealing with on a day-to-day basis in Mumbai in the hospital. They were related to a higher risk for heart disease in women. Things like pregnancy diabetes, pregnancy hypertension, then stillbirth, delivering a baby small for gestational age, having multiple miscarriages, none of those, having early menopause, whether it was, surgical, that means after a hysterectomy surgery, whether you had your ovaries removed or not, that was a risk factor for cardiovascular disease. Menopause itself is a risk factor for cardiovascular disease. So the list is endless. And unfortunate thing is not only are patients not aware of their personal risk, a lot of doctors don't know, and a lot of OBGYNs don't know either. And another thing is conditions like depression or mental health challenges, those are a much bigger risk factor for women than men. And of course, men and women are different in so many ways. First of all, if we start looking at the biological sex perspective. So sex is biological. That means women have XX chromosomes and men have XY. And obviously the Y chromosome is very different from the X chromosome. And each and every cell in our body has a different sex. So how can we expect women to behave as smaller men?
Right.
So that is one of the big things. And another big area, which is again an area where we can, as physicians, we can have an impact, is many a time women are not given the kind of guideline-based treatment that they should be getting. Now, this is sad because the treatment protocols already exist. And this is what I'm talking about from point of view of cardiology, but also the preventive aspect. Like I don't remember having this conversation with any women. You had pregnancy hypertension, you had pregnancy diabetes, two of the commonest problems we used to deal with. And I tell them, your risk for heart disease long-term is high. I have never had that conversation with anyone before. So over to you, Natasha.
Well, what's interesting is that you brought up depression, because I was at a conference a few years ago and it was a cardiologist presenting. And I asked him about, well, first thing I said was, isn't it interesting that there are serotonin receptors in the heart? And he was like, really? So that connection, like we always think that the body occurs in isolation, right? And so, we're dealing with depression, we're talking about serotonin, we're dealing with thyroid, we just think it's all about the thyroid, and yet there's thyroid receptors in bone, for example, and your TSH abnormalities can affect osteoporosis. And so I'm happy to hear you talk about depression, and then to tie it in that we have the depression hormone, or the thing that we associate with depression, serotonin, being low, and then we're saying you have a higher risk of heart disease. Well, there's receptors in your heart for serotonin. That's one thing. You're talking about sugar control, and I just don't know how we can talk about cardiovascular disease and heart health and leave out insulin resistance, right? I can happily leave out cholesterol because, as I've said many a time, I think cholesterol by itself is completely overrated, because if it actually made that much of a difference, then we wouldn't have the epidemic of heart disease that we have right now. Right? So there's something else, and I hope we can get to that. What is that something else? But, when we talk about women, we have a different set of stressors that impact women compared to men. The other thing is, you're talking about X and Y chromosomes, but let's just talk hormonally. Hormonally, we're completely different from men. And that impacts the risk for heart disease. So you always talk about this timing hypothesis. Can you just very quickly, because we're already halfway through this webinar, but can you very quickly say, what is this timing hypothesis and why does it matter?
Thank you, Natasha. So we are going to talk about hormones and heart on another webinar, but today what the timing hypothesis says is, now I'm not going into all the history of the world, the Women's Health Initiative, and how hormone therapy got the bad rep. And so essentially what recent studies have shown, that if hormone therapy, and that to appropriate hormone therapy, not oral estrogens and the progesterone, pretend, which is not a progesterone at all, the progestin, not that hormone therapy is what we are talking about. It's the different hormone therapy where estrogen is applied on the skin, and it's an oral micronized progesterone. So hormone therapy started earlier in menopause. So within the first 5 to 6 years after menopause, has shown a whole lot more benefits, particularly in relation to heart disease, stroke, brain function, and diabetes as well, versus starting hormone therapy later. Now, I don't want to disappoint all the people who have crossed that, the window. Yes, there are benefits even afterwards, but you will, number one, need a much more detailed assessment, because we need to know whether you already have existing cardiovascular disease and what the hormone therapy is going to do to you. But it's not that hormone therapy is not meant for you. It is there, it is meant for you.
And it can be very safe if monitored and tested appropriately.
Yes.
So, on this note, I know Wendy always joins us on all of our webinars and she helps promote them. So we have a very classic patient who had perfect body weight, looks gorgeous. She's not only beautiful on the inside, she's beautiful on the outside. She's slim and trim and looks the perfect picture of health. And yet when I assessed her, I said, you have autoimmune disease and you have insulin resistance and you're a vegetarian, which doesn't help the insulin resistance at all, and you're at higher risk for heart disease. And she didn't believe me. Or if she did, she didn't take it seriously, or, I mean, we'll let her tell her story at some point. Suffice to say that 3 years after trying to work on blood sugar control, correct the autoimmunity, and you and I, people don't believe this in general mainstream medicine, but you and I have reversed many autoimmune diseases over the years, and we can help people restore their health and suppress the autoimmunity. But, and that's a risk factor for heart disease, autoimmunity, right? And Wendy had a cardiac event, got airlifted out to a different city, had a stent placed, which, by the way, I don't know if our listeners are aware that having a stent does not prevent future heart attacks, right? There is no evidence to prove that when they put that stent in, that it changes your risk for a heart attack in the future. It just unblocked that blockage at that point. Now think about it. If you have a blockage at one point, you have blockages in other points, right? And so putting a stent in one spot has no impact on the course of the disease, which makes sense why the data is showing that stents have no impact on changing your future risk for heart disease. So I thought I would throw that in. But when she went to her cardiologist and she was asked about her medication, the doctor said, so what are you taking? And she said, oh, I'm on some hormones and I'm on this and I'm on that. And he was like, you've got to get off of these hormones completely, right? But didn't ask her which hormones. Right. And the fact of the matter is she was not on estrogen at that point in time. She was on testosterone and DHEA, both of which you and I know can impact estrogen levels. But if you look at the old data, and if you're looking at people who haven't kept up with the science, the old thinking was estrogen causes blood clots. Now we know it's synthetic estrogens and we know it's oral estrogens taken by mouth that affect your blood clotting risk. We know that the new North American Menopause Society guidelines say clearly that topical hormone therapy does not increase your blood clotting risk. It is safer and more effective than oral estrogens. But this doctor didn't even ask her, are you on estrogen? He just assumed because she said hormones that she was on estrogen. He had no clue what hormones do. He had no clue how they're going to help her. He had no clue about the timing hypothesis. And yet he told her to get off of them. An even worse thing that happened to the same patient is that she ended up with a different cardiologist, and she was talking about her triglycerides. And I had been harping about triglycerides, about insulin resistance, about, controlling blood sugar tightly. And this cardiologist tells her there's no such thing, that triglycerides have nothing to do with heart disease risk. And that's a whole bunch of baloney. Basically missed this thing completely.
Natasha, you and I have talked about this. If a doctor is not talking about triglycerides, and particularly in women, triglycerides and diabetes and hypertension are much bigger risk factors than the LDL cholesterol or any of that. And if the doctor didn't know that, he or she has not been keeping up. Very simple to say that. So
this is a heart specialist we're talking about. We're not even talking about a general
Natasha, a paper came out some time ago and I posted it on LinkedIn, I think, where 42% of cardiologists were not sure how to assess a woman for her heart disease risk. Family doctors, I can still understand. 42% of cardiologists were not comfortable. So that just tells us we have a huge opportunity to educate people about their personal risk. Now
let's do that. Let's do that. We've got 9 minutes left and we still have to.
I'm just going to try to put in a lot of information in a short time. So for all of you who've registered for this webinar, you will receive an email with, so I have a questionnaire on my website and you'll receive a link to that. And that is basically a checklist. So whether you've had, premature birth or any of those things are listed in that. But the important point is the point is, what can you do about your risk? Now, Dr. Iyer has been talking a lot about insulin resistance. So if you have belly fat, if you've been told you have PCOS, or you have fatty liver, or your liver enzymes are a little bit raised, or you need extreme exercise to maintain body composition, or you have hypertension, which is called primary hypertension, not from
High blood pressure, yeah.
Yeah, high blood pressure from the commonest one. All of these conditions indicate that you very likely have insulin resistance. And then, of course, if you're, Dr. Iyer's patient or my patient, you know that we do a very extensive lab work. We check your fasting insulin levels, we check your blood glucose levels, your post-meal insulin levels as well, and blood glucose as well. And another major blood test that is routinely done, Dr. Iyer, every patient of yours and mine gets that, is an inflammatory marker, HSCRP. And then, of course, there are a whole bunch of other tests. But another important test, which is again not covered by healthcare, but you'll receive a link to a testing, this thing is omega-3 fatty acids. So if your omega-3 index is low, that is a risk factor for heart disease. And most of the time, you are not going to get enough omega-3 from only your food, even if you eat fish every day. Most people don't eat fish every day. So that was just one more thing I wanted to mention. And so, Natasha, in the last few minutes, another thing is we can have questions as well. So, Natasha, after you conclude, I think we'll just open it for questions if you have any. Someone I thought had raised her hand, but I can't find out now. Sorry,
I see the hand raised, but I don't know
who it is. Not nobody else. I can't see the raised hand. But anyway, Natasha, after you conclude, we will take questions.
All right. So women present atypically. They can present with heartburn, fatigue, not feeling well. I would say to you, if you are in that perimenopausal and menopausal range, if you have palpitations, if your mood changes, if you start sweat. Now, this is funny because a couple of weeks ago, I was working in the ER and a lady came in with palpitations and I started investigating her for heart disease because, of course, that's the first thing you will do. And the other thing that's always top of my mind is microvascular disease, which we don't talk about a lot and it's not commonly known, yet I've diagnosed a few people with microvascular disease as a source for their chest pain. Microvascular means the tiny, tiny vessels, smaller than the ones that usually get blocked with a heart attack. And then the nurse, and she's been a nurse for, 40, 50 years now. And she said to me the most interesting thing. She said, I bet you she's just got changing hormones and she's in the menopause. That's why she has palpitations. And I thought, how interesting to meet someone in the field who actually understands there's an association and knows that there's more to it. However, as an ER doc, the first thing I have to do is exclude a heart attack. That's the first thing. Someone presents, you don't want to miss that. You do not want to dismiss it. But it can feel like anxiety. It could feel like shortness of breath. It could feel like just a heaviness in your chest with nothing else. So if you get any symptoms and you're not feeling well, don't feel like a burden. I have so many people apologizing to me for coming in with things like, honest to goodness, Shabnam, they apologize for coming into the emergency department to get checked out. And they're like, I should have just tried to wait it out. I'm sorry I came in the middle of the night. And I say, I'm here for a reason. And the reason is that if you need me, I'm here. You shouldn't. I would have, and I always say this to patients, I say, I would have no work if you knew everything and stayed home. And the same thing in our clinic. We see patients who want to live longer, healthier, more productive, and fulfilled lives. And there are so many things we can do. But for now, one of the steps I'd like you to take is to move and set your alarm to move every hour. Dr. Carr mentioned inflammation and an inflammatory marker that we check. But one of the things that we tend to forget to mention when we find inflammation in patients is how long are you sitting for? Because sitting disease is now worse than smoking. It's known to be worse than smoking. So sitting disease releases inflammatory markers into your body that cause you the underlying process that can lead to a heart attack, right? So the first thing, move. Well, actually, before you move, manage your blood sugar levels. I think that one's first, right? So blood sugar,
blood pressure levels as well.
blood pressure, but yeah, it's all important. Okay, so let's not categorize which one's more important, but you need to know what your blood pressure is. And in our clinic, we always do a 24-hour ambulatory blood pressure monitor on patients, because it's not only important to know if your blood pressure is high in the day, we need to know whether you're a non-dipper or a dipper. We need to know what your blood pressure is doing at night. And I have a lot of patients say, I don't have high blood pressure. It's only high when I go to the doctor's office. Okay, well then wear this monitor for 24 hours and let's see what it's doing, because the worst thing you could do is deny blood pressure issues and then have a heart attack because of it. Right? So high blood pressure and blood pressure abnormalities. Then your blood sugar levels. Insulin resistance precedes diabetes. This is where we intervene. We diagnose and treat insulin resistance. If you don't have a functional medicine doctor who's capable of understanding your insulins, your sugars, and predicting it far before it happens, then at least eat a low carb diet. At least work hard to get rid of your extra body fat, which is really hard to do when you have insulin resistance. So you should maybe see us and let us help you. I mean, weight loss is one of the things we're really good at, because when you put the body back in balance, the weight goes away without us focusing on the weight, right? But so it's high blood pressure, insulin, move, and then manage your stress. So meditation, mindfulness, walks in nature, spending time outdoors, focusing on your social relationships, hugs and kisses, self-care time, those sorts of things. That is also really important. Do you have a fifth one as important as these other ones?
Well, both of us love red wine, so I wasn't very sure whether I should bring up alcohol.
It's always 5 o'clock somewhere. I should switch this out for wine.
So yes, alcohol, particularly binge drinking. And for women, it's like one measure of alcohol a day, so 7 in a week. And 150 ml of red wine is very little. So it's very easy to go over that limit. So that is important.
It's three servings a week for women, right?
It's 7 a week for women, but not binge drinking.
For heart disease, sorry. And for cancer, it's actually more restrictive. It's 3 a week for cancer. Oh, thankfully, I don't have to worry about cancer, Dr. Carr. I'll just worry about heart disease. So you're saying 1 glass a day, every day, to protect my heart.
No, that's the upper limit. I know.
We don't make the rules.
We don't make the rules.
I just wanted you to tell me.
Yeah, so both of us love red wine. So, I mean, in case any of you think that, we're just being sanctimonious doctors, no. Okay, do we have any questions?
So just to clarify, the maximum is 1 5-ounce serving of red wine a day. And that's the maximum, above which you get negative results. And below that, it's protective. Because I have a lot of patients say, well, I read red wine is good for me, so I'm drinking red wine. And the point being, yes, please don't drink 3 or 4 glasses at a time, not even 2 glasses at a time. It is 1.
Yeah.
All right, Dr. Carr, we are so out of time. We don't have time for questions, but everyone knows how to get a hold of us. And so we will send out the recording to everyone by email if they registered. So do pop us questions, and then we can try to get to them at some point in our next webinar. Well, we've got 2 left, right? So if you miss us live, you can always join us by getting the recording, but you have to register.
Okay, I think we have 1 raised hand, so I'll just let her talk. Yes, Kathy, you can ask if you have a question.
Oh, she's muted.
No, she's on the phone.
Right, but I see it
Or
muted.
yeah, or in case it's not possible to open the audio this thing, please will you type in the chat box or in the Q&A? Actually, we are 2 minutes over the time.
It's okay. It's Kathy. Type up quick,
Yeah.
Kathy.
There, you unmuted me. I heard about this just after your video last week. And I was wondering if I can get a copy of what you did last week.
Yes. Are you registered now?
Yes,
Yeah,
I registered like just after you finished last week's video. And I
Okay.
sent, excuse me, sent an email seeing if I could get it, but it got lost in cyberspace somewhere.
So sorry about that, Kathy. Yeah, you will receive the recording. Okay, so thank you everybody for joining us, and see you all. Yes, you will get a copy of the first one. Yes, you will. And thank you everybody for joining us, and see you all next week again. Bye
Next
now.
week. Bye.
Bye.